So very good morning and welcome to all my delegates and my eminent speakers on this occasion of our Series 7 webinar on sleep apnea, an initiative of IASSA. Sun Pharma ENT Classroom is a platform through which we are organizing our series of webinars on sleep apnea. I think as the ISA series are progressing, our viewers are becoming more equipped to manage their variety of patients extremely well. This morning, our group of speakers are going to make it further more interesting, informative. I welcome Professor Rodolfo from Mexico, who is going to the first speaker today. Dr. Sandeep Bansal is from Chandigarh. Dr. Vidya Sagar from Vijayawada, Dr. Vijaya Krishnan from Chennai, and our today's moderator is Dr. Srinivas Kishore. So over to you, Dr. Srinivas.
Thank you for your kind words, Mr. Saha. And as usual, I would like to first thank Sun Pharma, as always. Dear colleagues, friends, teachers, welcome to the 7th edition of IASSA Classroom. This time, I have the pleasure of introducing giants in the field of surgical management of obstructive sleep apnea. My dear friend Rodolfo Lugo Saldana from Monterrey, Mexico, who's been so kind to have joined us in spite of the huge time difference. Just to get you an idea of what time it is in Monterrey, Mexico, it's 11:30 p.m. And he's been so kind and has been so generous to have accepted our invitation, because we, in this classroom, I think are going to benefit immensely from his expertise. I would like to also take the pleasure of inviting our dear colleague, Associate Professor from PGI Chandigarh, who's a COVID warrior, and all thanks to him, and invite him for this edition of the IASSA Classroom. Next is our President, R. Vidya Sagar, who we fondly call Bahubali. Thank you, Sagar, for another edition, and we're really looking forward to your way of doing the Z-Palatoplasty, and you are one of the principal contributors of this paper with Michael Friedman, so it's an honor for all of us to have you on board. And last but not the least, which Dr. Vijay, our Secretary of IASSA, who is actually going to talk on tips and tricks for palatal surgery, which is, I think, very, very important. Over to you, Rodolfo. Please go ahead and stack up your slides and start presenting.
Thank you.
Yes, we can see your.
All right. Thank you for the kind invitation. It really is an honor to be part of your webinars. I enjoyed so much your past webinars, and I think it's very nice to try to use this platform, these bizarre times, to COVID times, to make more relation between our countries, between our experience in this area. I'm from Mexico, from Monterrey, Mexico. I live in Monterrey. Monterrey is the third major city in my country. It's a 5 or 6 million people city. It's in the northeast. It's nickname our city, the mountain city, and the iconic landmark is the Saddle Hill. As you see, that hill in the right peak is the Saddle Hill. Cerro de la Silla is like a horse saddle, you know. It's a very industrial city, and I hope to see you all, my friends from India, come here in a time after these problems, you came here after the pandemic times here. Well, we start talk about the variations of lateral pharyngoplasty. I'm working in a public hospital and a private one, and in the public hospital, we need in the academic program with the fellowship, we need to and must to practice all the techniques we have. This is the reason we have experience with some of the techniques right now from lateral obstruction. We can talk about the multifactorial etiology, the choice of the techniques, the non-anatomical airway structures. You was talking about that in the past webinars, the hypotonic hemiglossus, the high loop gain, the low threshold, the peak rate, the palate position. Well, all that stuff we were discussing about that is very interesting. But I focus in the lateral pharyngoplasty techniques when I choose the techniques. The key factor is the muscle. The palatopharyngeus muscle is the key factor. You first view of the oral cavity in the patient in the office. You see some variations in the anatomical position of the muscle. You can make a measure from the gap, interpalatopharyngeus gap, the uvula, the webbing, the palate. This is very important to see that variations. This is an example from a classic UPP without dissection or mobilization of the muscle, only uvula cutting and resection of the palatoglossus, putting a stitch there. It's the classical view of the UPP. This patient, going back to our hospital with complaint or snoring complaint and apnea, still has apnea. We go to DEX. With the DICE DEX, I share the video. Look, this is still snoring. As you can see here, this typical case, post-typification, movement of lateral pharyngeus. Because the reason this patient is going bad with the outcome. Lateral. This is a typical lateral patient, lateral obstruction after surgery. And this is another failed case. This is my case. It's a ulopalatal flap without dissection or mobilization of the muscle. It's one of my first techniques I started doing in this area, the ulopalatal flap. I performed UPP, but in the residence. In my residence times, I performed a lot of UPPs, but in these times, we don't have experience with the classic UPP. This is the ulopalatal flap, which you see in no breathing patient. In the left peak, you have a widening space in the pharynx, in the oral cavity. But with the patient in nasal breathing, I see this situation. This is a space, widening space, but you see the difference in nasal breathing patient. During the breathing, we have the muscle is still working, still also has obstruction, and the middle palatal insufficiency there with the resection of the fat and the uvula. We make that insufficiency, and the patient is a failure. It's still also still obstruction, still apnea, and still snoring. Before we can talk about this, we need to understand the anatomy of the palatopharyngeus muscle. The palatopharyngeus muscle is so important. I think it's a key factor. Always talking about it's very classical to talk about the didgeridoo. The didgeridoo is a instrument, a wind blowing instrument from Australia. And this is a musician, a didgeridoo player, and Dr. Peter Batista, our friend from Spain, and I, during a course some years ago, we put the end. my didgeridoo too, and I started playing. It's very difficult to play this instrument, but it's very nice, and I recommend that. Well, I promise to playing the didgeridoo music in the next meeting when I see it. This is the anatomical view of the pharynx. The pharyngomandibular raphe, the palatoglossal muscle, the palatopharyngeus muscle, the tonsillar branch of ascendant palatine artery. The ascendant palatine artery of the tonsillar branch. This is very, 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 very important, you know. You look the raphe. This is very important in some lateral techniques, like the PRP, the Barbed ones. The palatoglossal muscle is not the obstruction one, but it's very important to make some movements there or resections to relocate the muscle there. The palatopharyngeus, the very important muscle, is the 28. And you see the artery. This is a very important artery. And always when you move the muscle or you dissect the muscle, you see that branch. And this is very important to make a nice hemostat technique there. With the monopolar or bipolar, it's very nice to make a nice hemostatic technique there. This is a close view of the anatomy. That artery is, you know, in some patients, this is very difficult to make the dissection. It is the reason I prefer to make the first step of dissection with the cautery of the bipolar or monopolar cautery and to move the muscle. If you move the muscle, you can put in any place you want. You only, you know, if you take the muscle and pull it or only make a loop with the suture and try to tense that, if you have a lot of tension there, you have problems after. You know, it's different, the outcomes. And this is palatoglossal muscle. I show you some dissection in this page. This is from our book, the Brownlee book of surgical manual. This is will release this year, but with the COVID problem, we need to make a new date. In the future, I think in 3 months, we can release that manual. This is a picture from that book. And you know, the prevertebral fascia, the superior pharyngeal constrictor muscle there, when you try to dissect and move the muscle. In another techniques, in this webinar, we will talk, one of the professors will talk about the Barbed sutures ones. It's very important, the Hamulus and the Raphe. That relationship is very important in Alianza, in the new Roman blinds and Barbed sutures techniques. You know, you see the close relationship between the lingual nerve and the pterygomandibular raphe and the hamulus. Is that the reason we need to be careful with when we put insert the needle there, because you don't have you know, if you put the needle in a bad position, you can injure the lingual nerve. And this is a very problematic patient, a lot of pain after the surgery. And this that you need to make a nice effort to localize the hamulus and the raphe. You see the lingual nerve there and the raphe, the number 36, and the number 10 is the hamulus. You see the relationship, it's a very close, it's very nice, it's very close. You need to have, you know, the landmark is the third molar. The third molar of the patients is very important to see the relation between the lingual nerve and the hamulus and the pharyngeal constrictor and the raphe of the muscle, the pterygomandibular raphe. This is a very close relationship. This is during a...
Vengo acá, presiono hasta la columna vertebral, que abro así, y la es la pasión. Preespinal.
Hasta la fascia preespinal.
Sí.
Esa blanca.
La
Sí,
bucofaringe.
la pharyngoplast is very
La Messenbaum.
application. The lateral aspect of the mobilize the muscle is you open the vertebral fascia in the upper part of the muscle, you can move the muscle without problems. This is very important fact, it's a very important step in this technique. In the new version, we don't talk about the lateral classical pharyngoplasty from 2004. This is the new modification of the lateral pharyngoplasty by Dr. Michel from Sao Paulo. Look, is it the fascia? And you need to be careful with this decision. Did you go under or you go down without cauterize this area? You have a lot of bleeding there. You know, in another dissection we have, you see, this is very, you put the dissection between the muscles, you don't have problem. This is mark data. That's the reason we don't go down there. You deep in the upper part, the uvula is over there. Part of the muscle, the fascia, between the two muscles there, you can dissect in this area. If you need to mobilize the muscles in the lower part, you need to cauterize it. And the bipolar is very nice instrument to do that. This is the tongue and this is the uvula. In the barbed ones, the relationship with the lingual nerve is very important too. And I was talking about that. You can injure the lingual nerve with your needle. I prefer use the Stratafish one. The big needle is more easy to me to use it, but you can use the below, the lower, very small needle there. But you see in this, when I put the sutures over there, you need to see the third molar in this area. To don't put in this area because you can injure the lingual nerve, and you don't put the barbed suture in the Hamulus or in the Raphe. That is the important point, the diverse collapse patterns. As you see a diverse obstruction collapse patterns, is that the reason we need to handle a different pharyngoplasty techniques? Is you know, the patient is not the same, and the obstruction collapse pattern is not the same. You see a patient over there is very different to the another patient. It's very logical to have a different obstruction pattern. You know, you see a lot of diverse obstructions, like these patients with a concentric one with a lot of flour of the palate. The uvula is working a lot there. You can see the lateral one, the classic lateral obstruction. In the upper part, I divide the lateral obstruction in two parts, the upper lateral, like a sphincter one, and the complete lateral obstruction. This is it's a complete obstruction, push the uvula, push the tongue, push the epiglottis. It's a complete obstruction. This is another lateral one, but some flutter there. And you know, if you cut the uvula and don't work in the muscles there, the lateral obstruction is going back. If you only take and only focus in the palate, the obstruction that the palatopharyngeal muscle is over there is going more effort to obstruction. Look, this is a complete one. It's a very complete obstruction. This is very common in the obese patients and the big BMI patients, but you know, is in this patient the lateral pharyngeal wall pushed the epiglottis too, and it's no obese patient. But you need to see you need to in this patient in this kind of obstruction I prefer the lateral pharyngoplasty. the classical one. This is another obstruction. And the, another concentric one that's very difficult to handle. Another key factor is the obstruction, the collapse, the complete lateral pharyngeal wall. We talk about this part. This is the lateral wall, it's a complete one. My surgery selection is the lateral pharyngoplasty. If you see this kind of obstruction, upper lateral, you see the palatopharyngeus muscle there. Look the work of the lateral. It's not complete, it's in the upper area. The epiglottis is free, the hypopharynx is free. The patient don't have problems with the base of tongue. You only need to open the sphincter area in the lateral part. In that case, my surgery selection is a palatoplasty with or without partial uvulectomy and recollocation pharyngoplasty with mobilization and dissection of the palatopharyngeal muscle. It's like a recollocation pharyngoplasty. And this concentric collapse is a lateral, anterior in the same way. If you try to treat all the muscle movement in this kind of patients. Well, in this kind of obstructions, it's very hard to do. My surgery selection is the new BRP. We have a good outcomes with the BRP, modified BRP. Our modification is dissect the muscle like a halidus, completely mobilization of the muscle, dissection of the muscle without cutting. There's a difference between the lateral pharyngoplasty and the barbed one, and make the barbed loops in the anterior, in the lateral, in all the pharynx is complete, and we can put the sutures loops over there. You can make a partial uvulectomy or not make any cut in the uvula. This is the second difference, cut or not cut the muscle. This is, when you need to cut, it's in two techniques. The lateral pharyngoplasty, the last version. In the blue, you see the muscle, the palatopharyngeal muscle. Or in the sphincteroplasty, expansion sphincteroplasty by Pan, Hagutson. I have my concerns about this technique because you make a cut, you make a cutting of the muscle, and you make a destruction technique in the muscle, and that muscle is not work. You cutting, and if it don't work, I don't know. We're doing well with this cutting and destruction muscle technique. Is that the reason I stopped to do sphincteroplasty right now and changed to BRP techniques with modified technique. And the knockout techniques too is the barbed ones, the Alianza, the new one, the new techniques about the Pharmacoplasty, the Roman blinds by Mantovani in the first years, and the BRP by Vicini. And another knockout technique is the recollocation by Dr. Lee from Taiwan. It's a very nice technique. I perform a lot. The first difference is dissection of the muscle, or just only a bullet technique. You see, this is a mobilization of the muscle. We dissect the upper part of the muscle with the bipolar. Is a very nice tool to handle the little vessels there and the blood supply of the muscle. And you can mobilize. If you mobilize the muscles, you can put the new position in any place you want. The second difference is cut or not cut the muscles. You see, if you do the lateral pharyngoplasty, you need to cut the muscle. It's very important to do the cutting muscle because it's a key step in this technique. You see, after you put the sutures and don't make the knot there, you can cut the muscle with a Colorado needle there. This is a cutting technique. Way down to the pharyngeal wall, over the rhinopharynx, the oropharynx. Look the myotomy. And is that in that point of the surgery, previous you make a stitch, a hemostatic stitch there, and you can put the sutures there and make the lateralization of the muscle there. Is that the reason we need to cut the muscle? The outcomes in complete pharyngeal lateral obstruction is going well with this technique. It's technical hard to do this dissection, but this is a very nice technique in the outcomes. You know, this is the sutures insertion of the needle. The muscle is loose there. You see it's dissected right now. And put 3 or 4 sutures from lateral muscle to the raphe, and you mobilize the muscle in the lateral aspect. You see, first you put the sutures. After you put your 3 or 4 sutures there, without nothing, you can cut the muscle there. In another technique, suspension Pharyngoplasty by Pan and Woodson, we dissect the muscles there. This is the mucosa, don't worry about it. You know, this is a muscle there. You can release of the constrictor muscles and recollocate the muscles over there to the raphe. The hamulus is very nice, but we prefer to put it in the raphe. In this second video, we see put the needle there and go to the cavity, make like 3 or 4 rounds over there, and going back in the new position. This is a good technique in the lateral aspects, but only in the upper. In the complete obstruction muscles, you cut the muscle there, and it's the same way of thinking. As you cut the muscle is not working. This is a tissue, a living tissue over there, but it's not working. It's not moving there. You know, it's. I think it's controversial in this point of view. But cutting and reorientation is a key step in this technique. Another technique we love to make is the relocation by Dr. Lee, but our variation is the immobilize the muscles. You can see the difference after the dissection. You can mobilize the muscle without cutting, and you change the vector of the movement. The second muscle relocation is this technique, not cutting technique, and it's not just a tension. You see the supratonsillar fat pad is resected over there. This is a graphics from our book. And you look, you can move the posterior pharyngeal palatopharyngeus muscle arc in any place you want. Right. And variations in lateral Pharyngoplasty, the Barbed one, we try to dissect the muscles in the first step of the surgery, no cutting technique, and put the Barbed sutures there. This is going well in this kind of obstruction. Look, the typical obstruction we see in these patients is an obstruction in lateral pattern in the upper part only. It's not complete, you know, it's only in the upper part. And we resect the fatty part too, the supratonsillar fat, and put the sutures in all the palatopharynx. You see, this is the difference between the techniques, the palatoglossal and supratonsillar fat wedge resection there with the Colorado needle. We resect the fat pad and make a little wedge from palatoglossal muscle. In the same way in another part, in another side. And we can prepare all the pharynx to put the barbed sutures. You know, in this image, you can see the pharynx prepare to put the sutures. And this is in the last view, the end of the surgery. This technique, we love to use this technique in lateral obstruction, but in the last times we used this technique to concentric ones. And this is nice. The outcome is very nice. Thanks. I hope you enjoy this presentation, and we stay here to the last part of the webinar to the questions and answers. Thank you. Thank you very much for your attention.
Professor Lugo, I think that was a fantastic explanation and demonstration of the anatomy. I've not seen such brilliant pictures, really eager to wait for your book. And the various techniques that are available to correct lateral pharyngeal wall. There are some questions that are coming, but as it has been informed to you before, we will take all the questions at the end of the presentation. But thank you very much. It was very nice.
Okay, thank you.
Thank you. Can I now invite Dr. Sandeep Bansal, please, to... Oh, thank you.
I hope it is
perfect. It is perfect.
Yes.
Thank you so much. Wonderful. Thank you. Can I ask Dr. Sandeep?
Hi. Thanks, Srinivas. I'll start with my...
Yeah. Did you open your presentation?
Yeah, just a minute. Just a minute. It was open.
Yeah, Dr. Sandeep sir, any?
No.
Is your...
No, I am not able to find my presentation here.
The first thing, go in a Zoom, sir. There's options for the share screen.
No. I am doing that. I was...
No, but first you have to open your presentation.
It was open.
Okay, so then go to share screen, which is the green button down.
No, Srinivas, I was able to do all that. I'm not finding my presentation in the share part, which I was there.
So that means you stop sharing your screen, stop sharing, go up, stop sharing, open the presentation, come back again.
The presentation is open.
I don't hear anything. I don't know if you can hear me.
Yes, I can hear you. I will mute you.
I can hear you.
Yeah, I will mute you. I will mute you. I mute you.
Sandeep sir, just first go in a Zoom and where you can see yourself. Can you see yourself?
Yes, I can.
There's a button called as share screen, green button. If you're using...
I've done it so many times. I'm doing it. We do it almost every day. But I don't know why the presentation is not there.
No, I think you should open the presentation.
Presentation is also open.
Oh, sir, open. The presentation is not there. When pop-up will come, you can scroll down. There is so many things is already open. That's why you're not able to see.
Yeah, I was I was able to see my presentation before. Now I am not able to see the presentation actually.
So why not you can share with the first option, whole screen, and then open a presentation, sir.
Okay.
Go in a share and select the first option.
Just now. The presentation should be there when I say share, na? The
Yeah.
presentation.
Yeah, sir. Basically, two way you can do. Either you can select your presentation, but if you're not able to find, just select the first option. In the share screen, there's a first option where you can share your full desktop. Click on that and click share.
I'm sharing the desktop, but okay.
Yeah, I think it's coming. Nice. There you go.
Now, can you see?
Yes, I can see your screen. Yes. Go ahead.
Okay.
Yeah. Sandeep, please go ahead with your presentation.
Sorry for this technical glitch. Okay. So after this excellent presentation by Dr. Rodolfo, I think we'll be able to understand this modification much better with such excellent illustrations of the anatomy and the detailed anatomy of the different muscles, So I'll be talking about my modification of the relocation pharyngoplasty. It's of course, like it's crucial to establish whether it is anatomic or neurological in nature, the OSA. And of course, the anatomy and the neurology will play a role in the OSA. So whenever we are operating a patient for OSA, we are trying to reduce the pharyngeal narrowing either by removing the pharyngeal soft tissue or by forward moving the maxillofacial skeleton to enlarge the pharyngeal lumen. Now, the strength of the lateral pharyngeal wall to sustain pressure is very crucial in the obstructive sleep apnea patients. And there are so many modifications which has been used for the lateral pharyngeal wall in the treatment of the surgical treatment of the oropharyngeal. Now, why are we talking about the lateral pharyngeal wall? It's the lateral pharyngeal wall is a very complex structure, numerous pharyngeal muscle groups, palatine tonsils, and there is enough literature which tells us about the pathogenesis and how the lateral pharyngeal wall causes the problem, and it is much thicker and collapsible in these OSA patients. And the narrowing of the lateral pharyngeal wall also is a sole independent risk factor in oropharyngeal findings in the male OSA patients when it's controlled for BMI and neck circumference. Now, so there can be different methods for splinting of the lateral pharyngeal wall, which can be done by either moving the maxillofacial skeleton advancement, as we said, or by the direct splinting of the lateral pharyngeal wall, as was demonstrated by Dr. Rodolfo and given by Kahali. The relocation pharyngoplasty basically involves the advancement of the soft palate and the splinting of the lateral pharyngeal wall, and to fulfill that, it increases the pharyngeal space and decreases the pharyngeal collapse by splinting the lateral pharyngeal wall. So it increases both the anterior-posterior and the lateral diameters of our oropharyngeal space. Now, according to Dr. Lee, the technique given by Dr. Lee as a relocation pharyngoplasty, he had put a few limitations of the procedure, that the patient should be having a webbed, thin, pliable posterior pillars. There should be a sagittal collapse of more than 50% in the retropalatal space. There should be a second degree lateral collapse on dice. So if we look at these limiting factors, it would be very difficult to put this technique into practice, especially from the part of the country I come from, because there are quite obese people here in northern part of India and thick palates. So we will never be able to find web thin pliable posterior pillars in our patients. So what I did was I am being using this technique very extensively with two basic modifications to this procedure, and it has been giving good results. The first, if we talk about the first modification, Dr. Dolfo was just talking about whether to cut the palatopharyngeus or not to cut, and why doesn't he like cutting the palatopharyngeus. Uh, what the modification which I make was at the lower 1/3 and the upper 2/3 of the palatopharyngeus, you just give a small release incision on the palatopharyngeus. Like, we do not cut the whole of the palatopharyngeus muscle, just releasing the palatopharyngeus so that it becomes more flexible, it becomes more pliable, and you can take it a bit more laterally. Like, if you're trying to reposition this muscle without the cut, then maybe there'll be tear through of the muscle when you take it to laterally and tie it to the pterygomandibular raphe. So this is the first modification. So now we'll be talking about the normal palate of the relocation pharyngoplasty. In the as was given by Dr. Lee in his article, that we make the uvula, you make semilunar cuts in the palatal supratonsillar fossa area, of course after the tonsillectomy, and you remove the mucosa, you remove the submucosal glands, and and as demonstrated by this, like, you try to take this part to the point C. Now, after removing the mucosal and this submucosal adipose tissue, this the removal of this adipose tissue, the palatopharyngeus would be bare, and we have to take this palatopharyngeus to the point C as was given. We remove the supratonsillar pad of fat, and then we can, like, there are two ways of doing it. One is you can just pick up the bulk of the palatopharyngeus, which has already been released, and instead of tying it to the palatoglossus, which was given in the relocation pharyngoplasty technique by Dr. Lee, you take this palatopharyngeus and suture it to the pterygomandibular raphe. Through and take it to the raphe. Now, there are two methods. One is you can just directly take, as was shown in this video, you take the bulk of the muscle and take it and tie it to the raphe, or you can start the other way around. You can take it through the raphe first, then take it out in the tonsillar fossa, and then take the bulk of the palatopharyngeus, and then take a reverse suture again with the bulk and take it out to the raphe. So it will give reinforcement there, and secondly, the sutures will all be inside the muscle tissue. None of the sutures would be seen outside except the knot at the pterygomandibular raphe. So either you can go like this and tie it to the pterygomandibular raphe, or you start from pterygomandibular raphe, go to the muscle, take it loop around the muscle and take it back to the pterygomandibular raphe and tie it here. So the two modifications for this classical relocation technique is that, one, you release the palatopharyngeus at the lower 1/3 and the upper 2/3. Do not cut it completely, just release it so that it becomes more pliable. And second is, instead of repositioning it with the palatoglossus, you take it to the pterygomandibular raphe and you tie it there. That are the two modifications. And this technique can give you very good results by these doing. And then if like you can do a partial uvulectomy if needed according to the thing. Now, the advantage is that once you pull the palatopharyngeus in the cephalad direction and you tie to this pterygoval raphe, you are not only increasing the anteroposterior space, you will be increasing the lateral space, will be increasing the anteroposterior space also in this. So the magnitude of the forward movement of the solved palate will depend upon how much you have been able to, take the pillar, the traction by the traction, posterior traction of the posterior pillar. Now this technique, like you can go on to the other side and complete the procedure, do a partial uvulectomy, and you feel that the palate is still thick, or like on dice, if you see that you can add a anterior palatoplasty procedure. It's just a 5 minutes procedure which we can add to this technique to complete the procedure. Now this is a diagrammatic representation of this modification, that we release the palatopharyngeus, and then from the raphe you take it loop around the palatopharyngeus and tie it to the raphe again. So this is what is the complete procedure, and then you tie the sutures, the pillars also. You can do this with a normal suture also, and you can do it with a barbed suture also, depending upon your preferences. Now, how is it different from lateral pharyngoplasty? And how, the results are comparable, as was shown by Dr. Lee also, with the lateral pharyngoplasty. Now, the lateral pharyngoplasty requires a lot of dissection of the superior constrictor muscles, and you have to be careful about the ascending pharyngeal artery too. Now, this relocation pharyngoplasty, it prevents all this extensive dissection. The superior constrictor muscle is not disturbed, so it will not lead to any dysphagia also. It is simpler, less time consuming. And it is also hypothesized that the suturing of the in relocation will placate the superior constrictor muscles along with the palatopharyngeal, and it will rebuild the tonsillar fossa, thus avoiding the cicatricial effect of the tonsillar wound, which in turn, over the period of time, may pull the tongue posteriorly. So it might increase your retropalatal space, but it will decrease your retrolingual space. So the same problem was seen in the usual UPPP when there is a narrowed retroglottal space because of the cicatricial effect of the base tongue and the tonsillar fossa being remaining raw. Now there was velopharyngeal insufficiency after relocation pharyngoplasty also. These are the few post-operative pictures of this modified relocation pharyngoplasty. Of course, we need further studies to validate and this procedure and how about its nasalence, nasality, voice, articulation, and all the things. And of course, how much improvement does it causes in the other parameters. Now, summarizing, you can say that relocation pharyngoplasty can be an attempt to rebuild the narrow pharynx by advancing the palate and splinting the lateral pharyngeal wall. It enlarges the pharynx and prevents the pharyngeal collapse. By these two modifications, you can try to, you can use in any different kinds of palates. And the inclusion criteria can obviously be increased to include all different kinds of palate by these two modifications. We have already seen the surgical technique. I would just like to show done a few patients. And of course, this cannot be a standalone procedure according to the findings of the drug-induced sleep endoscopy. We might have to combine it with the advancement palatoplasty, or sometimes if there is a laryngeal obstructive sleep apnea, we need to take care of the epiglottis, the hypopharynx. So this is, and we might have to stage the procedure. So these 14 patients this chart gives the initial and the final AHI. And of course, some of these patients have to be taken up for the second stage surgery. So this is just as the modified relocation pharyngoplasty, only the modified relocation pharyngoplasty. So we have, kind of the results are from about 50% to 95% in these patients. And if we, according to the other parameters, if we correlated, it just correlated with a significant correlation with neck circumference and the initial BMI. So some quality of life parameters are also taken as sleep apnea, quality of life index, and functional outcome of sleep questionnaire were used, and they were found to be significantly better after doing the relocation pharyngoplasty in these patients. So from my initial AHI, if mean was 53.9, so to 19.2. Some of these patients have already undertaken their second stage surgery. Some are still living, and we are just validating this data. Thank you so much.
Thank you very much, Dr. Sandeep. That was a brilliant explanation of your modification of Shuyuli's relocation and the rationale as to why you've modified and the advantages of your technique. And of course, there are lots of questions that have actually come in, but we will do the question answer session at the end of the webinar. So folks, stay there. Let me now invite Dr. R. Vidyasagar for his talk on Z-Palatoplasty, how he does it. Sagar?
Good morning, everyone. At the outset, I want to thank IASSA and Pharma for wonderful initiative on the OSA classroom series. And thank you, Dr. Srinivas, for wonderful introduction. And more importantly, both the previous speakers, both Dr. Sandeep and Dr. Rodolfo Lugo made an excellent stage set for me, so that I can proceed with my presentation of Z-Palatoplasty. Before I begin, Srinivas, am I audible?
Yes, loud and clear.
Oh, thank you. And are you able to see my presentation?
Yes, go ahead.
Perfect. Okay, thank you. So, my topic of the day is Z-Palatoplasty, how I do it. So, I think in previous talk, Srinivas has wonderfully told us that the palatal level or the velopharyngeal collapse approximately contributes to 81% of the total obstruction that we see in OSA patients. This obstruction can be either an isolated, that means only at the velopharynx, or it could be a part of multi-level collapse. And we have also seen wonderfully with Dr. Rodolfo's presentation how various types of phenotypes that exist. And we have also seen that there is various type of collapse that we can see in the dice and to the varying severity. The next thing that we need to see, or in other words, how am I going to identify the patients for Z-Palatoplasty? So if you see at the oropharynx, you may have various types of phenotypes of palate. You may have a thick and bulky uvula, or you may have a long, elongated, flimsy uvula, or you may have a previous tonsillectomized patients, or you may have a patient who had undergone a previous palatal procedure with a lot of pharyngeal scarring. And these are the patients that I would choose for my Z-Palatoplasty, provided they've undergone this drug-induced sleep endoscopy, wherein you get this kind of collapse. What is this collapse? This is a circumferential collapse. So if you have a patient with a circumferential collapse and if you have bulky uvula or palate, which I see more often in my practice, then Z-Palatoplasty is going to be the workhorse surgery for my patients. So what is Z-Palatoplasty? As Srinath said, I was so fortunate to be part of this procedure in 2004 when we published this, wherein we make a butterfly-shaped incision in the mucosa of the soft palate and the uvula. And then we divide the uvula and soft palate in the midline. So we will have two flaps like this, and just we rotate in an anterolateral dimension like this, and we suture it in 2 layers at least. By doing so, we get a vector of healing in an anterolateral dimension. So not just that, we can also appreciate how there is a widening of the pharynx in the lateral dimension, that is pillar to pillar is also widened. You can see there is an increase in dimension of the cephalocaudal dimension, and there is also an increase in the dimension in the anteroposterior dimension. So it acts in all the way, both anteroposterior, lateral, and cephalocaudal. That's how it is helping us in treating the circumferential collapse. So now we have identified the patient who is planned for Z-Palatoplasty. As in all patients who are taken for surgery, it is more important that the patient has undergone a CPAP trial, and only the patients who have failed in a CPAP trial, and only after you have ruled out that there is no other static obstruction, you proceed with this surgery. So the first and foremost thing we do is, in the outpatient clinic itself, we identify the most important thing, what is called as palatal dimple. This palatal dimple is corresponding to the palatal aponeurosis that Dr. Dipankar Datta showed us in the anatomy class. So you have to mark that palatal dimple before you proceed with the surgery. This is very nicely done in your outpatient clinic. You can mark with the marking pen or with your methylene blue. And then once you take the patient for surgery, you need to pass the endoscope transnasally, and you can see the configuration and the severity of the collapse that you see in the palatal region. So this you need to document it. The other thing you also need is you have to keep the patient in the rose position with the mouth gag, and you have to slide your finger, the middle finger, from the alveolar ridge in the midline through the hot palate, cross the hot palate soft palate junction, you make a marking there, and then you glide your finger down and you locate the palatal dimple. And if your endoscope is through the nasopharynx, if you can see at the point where the palatal dimple is there, you will see that the palate will touch the posterior pharyngeal wall. You mark that point, and then you proceed with the surgery. So here, this is the marking that we have done with the methylene blue, and then I go ahead with the marking. So I make this marking here. This is the palatal dimple, and I take another mark that is approximately 0.5 millimeters below the palatal dimple. The reason we do this is we don't want any of our resection or dissection to be above this palatal dimple. If we go above this palatal dimple, there is a chance of velopharyngeal incompetence. As long as if you are staying below this palatal dimple, the chance of velopharyngeal incompetence is very, very negligible. So now what we do then, we mark a second point. The second point is just at the level of the pterygoid hamulus, or just below this. This is the second point. This is approximately posterior and below the third molar tooth. You can feel it with your finger, you can palpate it, and this becomes your second point. The third point is going to be in the arch, palatal arch, that is the palatoglossal arch, approximately upper 1/3 and lower 2/3. This is going to be the third point. So now what I'm going to do is I'm going to connect these points, all the 3 points on both sides. You can use your radio frequency, you can use your monopolar, you can use your cold steel, you can use your coblation. Here in this patient, I'm using the radio frequency. So now what I'm doing, I'm just elevating only the mucosa and the minor salivary glands. It is so important that we don't disturb any of the muscles and we only elevate the mucosa and the minor salivary gland over the marked segment, that is the butterfly segment that I have marked it before. You will come across two vessels. One is the descending palatine artery that will be coming here, and you may come across an ascending palatine artery right here when you are making a suture here. So this is the descending palatine artery. You will have to control it with your bipolar only if you come across the bleeding. And the next step is what I'm going to do here. I'm denuding the mucosa over the uvula also, but preserving the musculus uvulae. So in traditional Z-Palatopharyngeoplasty, we won't cut this palatoglossal arch. We divide the uvula and soft palate and midline and we will reflect. But the modified Z-Palatopharyngeoplasty, the modification what we have made is, we will be resecting or dividing in 45-degree angle the palatoglossal arch. The reason we do this is, if we do the division of the palatoglossal arch, we can achieve even more pull in the lateral dimension. You see, after I divide the palatoglossal arch, I can take my suture and I can take this posterior filler muscle, that is the palatopharyngeus muscle, and I can suture it all the way to the pterygomandibular raphe or to the pterygoid hamulus periosteum. So that is why we divide that. So now the next step is we divide the uvula and soft palate in midline. So to take care to prevent any thermal damage to the posterior pharyngeal wall, we can keep a gauze piece in the posterior pharyngeal wall and then we divide it. How long you have to come up? You can use your measuring instruments. See here, I am using the measuring scale and seeing how much of velopharyngeal advancement I needed. So here I saw that there was a pillar to pillar dimension was 1.5 to 1.7 centimeter before. And once I divide it and pull it, I can see that more than 3.5 to 4 centimeter widening, I can get it in the lateral dimension. So once I know that adequate dimension is achieved, then I once again use my finger to palpate that I have not violated or gone beyond the palatal aponeurosis, and then I start my suturing. The first suturing is going to be from the palatopharyngeus muscle here to the pterygomandibular raphe or the pterygoid hamulus periosteum. So this stitch is most important, or the key step. In the traditional Zeta, we used to take the stitch from here and here to here. But in the modified Zeta, this is the key important step. We do a stitch from the posterior pillar muscle and we suture it to the pterygoid hamulus periosteum here. So this widens the velopharynx in the lateral dimension. This stitch, what we are doing, widens in the lateral dimension. You can see that a part of lateral pharyngoplasty is already done, that what Lugo had shown in his previous presentation. This procedure combines the lateral pharyngoplasty also. So that is why it is widening in the lateral dimension. So first and foremost, we do only the muscular suturing like what I am showing here. We have reflected the flap anterolaterally and we are suturing on both sides. So first we do the muscular suturing to address the lateral collapse. Then we do the anteroposterior suture. This will be done in a vertical mattress suture, and this suturing pulls the palate in the anteroposterior dimension. Thereby, you are widening the velopharynx also in the anteroposterior dimension as well as in the lateral dimension. Once I do the muscular suturing, then only I go on for the mucosal suturing. The mucosal suturing is so important so that if there is no submucosa is exposed, then the chance of pain is less. And you can also notice that when I'm doing this suturing, when I'm doing this suturing, it is without tension. This suturing should not be done with the tension. If you do it with the tension, this suture may give away and there is a chance that the flap may fall off. And this procedure can also be combined with other multi-level procedure if you want to do it. So at the end of the procedure, you compare your pre-endoscopic picture that you have taken it with the post-operatively. That is, intraoperatively itself, as soon as you finish your Z-Palatoplasty, you insert your endoscope transnasally and you can see how much of widening you have achieved. You can also see the endotracheal tube that you have passed it, and you can compare it with the pre-op finding also. So this for sure is going to be successful. But how are we going to document whether it is going to be successful or not? And how do you know that the patient will not get VPI for sure? There is a technique that we follow it. One is, as you are passing the endoscope after the procedure, we push the velopharynx at the level of the palatal aponeurosis and see if it approximates to the posterior pharyngeal wall like this. So if it is going to approximate, then there is no chance that the patient is going to have any velopharyngeal incompetence. The second thing what we do is we insert a Yankau's suction through the oral cavity into the velopharynx and create an artificial suction and see if this structures collapse. And if there is no collapsibility of the structures in spite of passing your suction, then it indicates that approximately that this patient is going to be your successful candidate. And how does it differ from the classical zeta? I had told that in classical zeta, you don't divide the palatoglossal arch, but in the modified zeta, you do divide it. So how is the patient's postoperative status? One of the reasons the patient may complain of the pain is if you have improper mucosal suturing, thereby you are exposing the underlying muscle. If it is happening, then there is a chance that the patient may have pain, not only pain, but there can also be little bit of sloughing that you see in your post-tonsillectomy fossa. And if in case there is a tension suture, it is going to open up when the patient is going to swallow. And that is why I reiterate that there should not be any tension suturing. And approximately in 2 weeks, you will start to notice that the sutures will slowly get absorbed or give off. And approximately in 4 to 5 weeks, you can see a beautifully healed velopharynx post Z-Palatopharyngeoplasty with the vector facing anterolaterally, so that there is no chance that the patient is going to have any velopharyngeal stenosis, or the patient is not going to have a velopharyngeal incompetence because your incision is below the palatal aponeurosis. Recently, we have started to use the recent kit in the block, that is the Barbed. We have started combining the most disadvantage that our young ENT surgeons complain about Zeta is the suturing. So to reduce the amount of suturing, we started using the Barbed Zeta. And this is a patient where we have used a Barbed Zeta.
So this is a Barbed assisted Zeta palatoplasty.
What I see with
you can
my
see a small Barbed stitch
Barbed Zeta
right
is
there.
that there is a chance that
otherwise everything is fine. Another small.
There could be the exposure of this Barbed suture that can actually hitch on the tongue, and it could cause more of a foreign body sensation, and that suture you may have to trim it off in the postoperative phase.
Barb stitch was there, we just removed it. So otherwise he is fine. This is the Barb assisted Zeta Palatopharyngeoplasty.
So postoperatively, these patients do phenomenally well as well. So can the Zeta be done in other type of collapse? Yes, it can be done. Having said that, you have other good procedures to less invasive procedures or less aggressive procedures like anterior palatoplasty or uvulo-palatal flap for anteroposterior collapse, and beautiful lateral pharyngoplasty or a relocation or expansion for your lateral collapse.
subscapularis breakthrough.
But when it comes to circumferential collapse with the thick and bulky uvula and soft palate, then the best procedure, at least in my hands, is the modified Z-Palatopharyngeoplasty. I know for sure that the suspension bridge also works, that is the process technique also works, but in my hands, the modified Zeta works phenomenally well. So, not just this, you can also use Z-Palatopharyngeoplasty in the late complications of the previous UP3, not the Zeta, the UP3 can cause this kind of velopharyngeal stenosis. And herein, I'm going to quickly show that we have used the classical or the Zeta in addressing the most severe velopharyngeal stenosis. This is an old video. That's why kindly excuse me for the poor quality. My hot instruments here. I'm using only the cold instruments. I'm using only the cold knife, and I'm making the same butterfly incision, and I'm trying to elevate only the mucosa. And here you notice that unlike my modified Zeta, wherein I remove this and discard this mucosa, but here you can see that I elevate and preserve this mucosa that I am erasing from the stenosed part of the velopharynx. So once I erase this and I leave it over the attached to the postpharyngeal wall, then I pass my artery forceps from the nasal cavity on both sides, and then I try to open up the stenosed velopharynx. And once I identify that, I use my cold instruments again, and I make it into a bigger opening like this. And then I start to divide. I see where my opening is made. Then I start to divide the residual uvula and soft palate. Once again, care is taken to be below the palatal aponeurosis. And now I have two flaps, and I suture it in layers like what I have told. I take this suturing muscle to muscle and pull it to the anterolateral dimension, and then I use this mucosa. This mucosa will be also sutured to the postpharyngeal wall mucosa here. So by doing so, we get a mucosally lined velopharyngeal airway. Thereby, it does not recur and it does not have any velopharyngeal stenosis nor velopharyngeal incompetence. So thereby, Zeta helps us in addressing the post velopharyngeal stenosis patients also. So coming to the results, because it has been there for more than a decade, there are multiple papers that says that the subjective improvement with the Zeta is anywhere between 88 to 95%. That is by your quality of life survey assessment and by Epworth sleepiness scale. And the objective assessment in selected patients is anywhere between 70 to 88 patients, depending on whether you are addressing a single level or a multi-level. So when not to do a Zeta, because it is an aggressive procedure, I would rather restrict it not to use it in a pediatric OSA. I would rather go for either a Barb or a ESP or a less invasive procedure in a pediatric OSA rather than doing a Zeta. Having said that, if it is a revision, then you can still use a Zeta. Even in mild patients with OSA, with the thin, soft, short uvula and soft palate, I would try to restrict using it to other surgical procedures like ESP, AP in combination. And the patients with more than BMI of 35, I would rather not use the Zeta as a procedure for dynamic obstruction alone. To conclude, Z-Palatopharyngeoplasty and the modified Zeta are wonderful surgical techniques to address the velopharyngeal collapse. It can offer high success rate in properly selected patients, even though it can be done in all the type of collapse, as it widens the velopharynx in anteroposterior, lateral, and cephalocaudal. It is more suited for circumferential collapse, especially The patients with post-tonsillectomy patients with a lot of scarring, because of this being an aggressive procedure, it can be done even in the post-tonsillectomy patients also. And it can also be used as a salvage procedure in the nasopharyngeal stenosis. And of course, it is an aggressive procedure, hence it has to be used very judiciously. But in my practice, it has been the workhorse of addressing the velopharyngeal collapse, because in my practice, I see more of circumferential type of collapse with bulky and thick uvula and soft palate. So that ends my presentation. Thank you very much for your attention and for this opportunity.
Thank you very much. Thank you very much, Sagar. It was a very nice presentation with excellent videos and your rationale as to why you would want to do a procedure at this time and era where Barb is sort of, trying to take everything away. So there are a lot of questions, Sagar. Please stay there.
Sure.
Yeah, and if you can stop sharing your screen, I would like to invite Dr. Vijaya Krishnan, last but not the least, but I think he'll have a lot of valid points, especially, and his title of the talk is Tips and Tricks for Palatal Surgical Outcome. Go ahead, Vijay.
Yeah, good morning one and all. I would like to welcome you all for this Iassa Classroom webinar series 7. Today, almost this is a last talk on palatal surgery, and most of us would have explained you in detail about every surgical procedure and how to get success out of it. So this is actually a take-home message kind of nutshell. So ultimately what everyone would have said is proper workup is the key for your success. So identifying the type of collapse, severity of the collapse, level of obstruction, to keep in mind that multi-level obstruction is very common, and the pattern of obstruction, so that you can choose which surgery for your patient. So basically, there are a few factors you have to keep in consideration, like surgeon's factor, like what is your knowledge about OSA, and definitely training and learning curve plays a major role in choosing the patient for surgery and the technique what you are going to use, and the hospital facility where you are working. So preoperative workup, necessary equipment. So all these will be discussed in detail in the forthcoming class series on Sunday. How to set up a sleep clinic will be discussed in detail, and managing post-op complication is very important before you touch a patient. So ultimately, we all know that OSA is a multifactorial disorder. So multidisciplinary board is a must to get a good success out of the patient's problem. So patient factor, what is the expectation of the patient and his family? And proper counseling in the presence of spouse is the most important. And assessing the comorbid conditions and the severity of the disease. What is his BMI? The component of static and dynamic obstruction, single or multiple level obstruction. All these are very important when you are choosing a patient for surgery, which will ultimately give you the outcome. So all of us wants to have 100% outcome. Though we can't reach 100%, at least we should be aiming for 80 to 90%. So as I told you, we all obstructive sleep apnea is a syndrome, and it is a multifactorial. Proper knowledge about what is OSA, what are the causes of OSA, the anatomical structure, what we are dealing with is very important. I'm trying to pertain to palatal surgery. So classification of soft palate, like House, what type of soft palate you are dealing with, whether it is a tunnel shape or funnel shape, all is important when you are choosing a patient for surgery. So here you can see in a dynamic MRI, this is a straight velum. It is a tunnel-shaped velum. Here you can see it is minimal adenoid is there, but you can see the funnel-shaped. It is an obliquely placed soft palate. So these are all very good surgical outcomes. If you are going to choose this patient for surgery, soft tissue surgery, you will fail because the hard palate is coming up to this point. So you have to be very choosy. Choosing the right procedure for the right patient is the key for success. So as I told you in the beginning, for the surgeon, training is most important. Attending many lectures, conferences, and we have IASSA certified training program, 2 months structured training program. which will help you to assess how to assess the patient, how to counsel the patient, how to manage the postoperative complications, etc. So the next thing what I was telling is about choosing the right instrument for your patient. So which instrument, where you are going to use. If you are going to use laser, no, because laser is not being commonly used. So harp instruments not usually used, because our aim is to get a good scar out of the surgery. So, and the scar has to be guided by you, not in its own way. So we have to guide the scar in which direction you want the scar. That is the most important principle of the surgery. So we here, you can use coblation or radio frequency according to the surgical option you have. So microscope, endoscope, so many are, but I would prefer and suggest microscope for palatal surgery, where the thing is very stable. Here, endoscope, you maybe keep on moving the endoscope unless you use a stand, endoscopic stand or something. But in the tongue-based surgery, you may have to use endoscope. So which all is important for your safety and the patient's safety. Choosing the right instrument, so EVAC 70 or ProPrecise Max or channeling instrument or turbinate channeling instrument. So choosing the right instrument is also very important. The most important thing is the irrigation versus suction. It should be balanced. Too little of irrigation will not be sufficient. It will make the electrode clogged or blocked and incomplete formation of plasma. Too much of irrigation also will irrigate. It will dilute the saline and it will not form a good plasma. So balanced irrigation and suction is very important when you are doing these kind of procedure, as we commonly use coblation in most of these surgeries. So counseling, as I told you, counseling. So counseling the patient in each and every step of the success factors is important. Keep talking. So you explain them the maximum information you give him, what are the complications you can expect? What are the other alternative options you have? What are the, I'll be discussing in detail in each and every step. The next thing is about anesthetic consideration. So pre of counseling, even the anesthetists have to counsel the patient. What are the complications they expect during the anesthesia procedure, and get a consent, proper informed consent for anesthesia in these patients. Most of these patients are, we can expect a difficult intubation, so prepare for it. Avoid opioid drugs as pre-anesthetic medication, and you can give injection glycopyrrolate, which may make you easy to suture. Intra-op, you can pack a nasal cavity with xylocaine with decongestion, so that you can, if needed, if you have to put a nasal intubation, or if you want to do a fiber optic intubation, that will help you. So first, you have to communicate with your anesthetist and choose the right, which side you want to intubate through the nose. And you can discuss with anesthetist to have a hypotensive anesthesia. And most important thing is, before extubation, bring the blood pressure to normal so that you can arrest if there is any bleeding. Post-operatively, nasopharyngeal airway is the key, especially when you are dealing with OSA patients. Keep nasopharyngeal airway for at least 2 to 4 hours till the patient is fully awake, and give IV fluid and make the patient comfortable. Intravenous infusion of paracetamol, and avoid opioids and sedatives. Monitor vitals in the ICU or high dependency unit is a must. Respect the soft tissue. This is most important factor when you are handling the palate. So less the trauma, less the pain in the postoperative region. So respect the soft tissue, handle with care. So the most important thing which we are worried about is few things like hemorrhage, pain. So pre-operatively, when you are counseling the patient, explain and check for whether there is any bleeding disorder, and check his coagulation profile, and explain the patient about the chance of secondary hemorrhage and the readmission, possibility of readmission, even blood transfusion may be needed. So all this should be kept in mind when you are discussing with the patient. So intraoperative, as I told you, handling of tissue, instrumentation, how you are handling them. Saga was beautifully explaining last in the class how to take out the warned when you are actually coagulating a bleeding point. So all these are very important when you are dealing with bleeding intraoperatively. Less the coagulation, more you use coagulation. Over, just keep the instrument tip near the bleeding point and press coagulation pedal. That itself will stop minor small oozes. So you can use tranexamic acid by injection or local application, and you can give adrenochrome or streptochrome injection, and keep the patient hypotensive so that the bleeding will not be too much and blood loss will not be too much when you are doing with multi-level surgery. Post-operatively, start with chilled, clear fluids, ice cold water, ice cream, ice fluids, and even in the post-operative, if the patient complains that there is a little bit of blood-stained saliva, you can ask him to have some ice cubes so that will chew the ice cube, so that will reduce a little bit of small oozes which can happen during the post-operative period. So pain. So how we are going to manage pain? Pre-operatively, as I told you, again, counsel the patient that the pain may increase and then decrease in the post-operative period. Maybe initially for a couple of days, even there not be even pain. So explain that the pain can happen, especially when you are dealing with extensive procedures or aggressive procedures like what Iassa was describing, Z-Palatoplasty, where you are dividing the muscle, etc. So whenever intraoperatively, as I told you, handling of tissues is very important. Avoid injury to nearby tissues. Like if you want to preserve uvula preserving surgery, make sure you don't injure the uvula, and avoid dividing the muscle as far as possible. But the procedure warrants you to divide the muscle. You have to avoid tight sutures. See, the pain can happen, as always Vikas says, the pain usually happens because of two things. One is putting a tight suture against which when the patient trying to swallow, you'll be having pain. At the same time, the other pain is because of the mucosal injury and the muscle injury, where the inflammatory factors play a role. So local sensarkine injection in the site, which will help, or paracetamol suppository, like you can see here. So in these kind of minor procedures like radiofrequency assisted palatal stiffening procedures, go through the mucosa, remove the submucosal glands, and you can see the aponeurosis, and little bit if you remove, the muscles will come, and stop there. So don't go beyond that level too, so that the pain will be very less. Intraop, you can inject sensarkine in the posterior pillar or in the palate. I use 0.5% sensarkine, and you can use, this will give us immediate pain relief in the post-op, and the patient will be a little comfortable. Post-op, a lot of medications available. Usually I will try to avoid NSAIDs and opioids. So you can give a simple paracetamol infusion, and in the post-op after discharge, you can give paracetamol, plain paracetamol, or lidocaine with lignocaine chewable tablets or gargles. In severe cases, you can give gabapentin or patches like fentanyl or diclofenac patches are available. And especially better to avoid NSAIDs when there is a tendency for any bleeding. So as I told you, pre-op counseling is very important, and intra-op handling of tissue, and post-op steroids and pregabalin or gabapentin are also recommended. Next common thing which we are worried about is the velopharyngeal incompetence. So here, explain the patient that there can be a temporary velopharyngeal insufficiency, and the fluid may come out through the nose when you drink, especially in the aggressive procedures like Z-Palatoplasty, or when you are combining expansion sphincter pharyngoplasty with anterior palatoplasty, where you want to pull the palate in all possible directions. So if you are going to, as Sagar was telling, if you are going to do Z-Palatoplasty for a thin palate or not a severe OSAS patient, severe anatomical obstruction, then the chance of velopharyngeal incompetence is higher. So choosing the right technique for that patient is very important. Avoid dividing levator and tensor palatine muscle. Avoid crossing the palatine dimple. That is most important. That Actually, beautifully, Vidyasagar was showing the Palatal Dimple pre-operatively. Post-op pain management is also very important. Here, this is what the anatomy is very important. The Palatal aponeurosis comes here, and you should not be going beyond that level. And intraoperatively also, you can assess by marking the base of uvula there and the hard palate soft palate junction here, and the midpoint. Usually, the midpoint will be the intersection of palatal aponeurosis and the levator palatine muscle, tensor palatine muscle. So that's the point. Usually, that will be confirmed by pushing with a finger and touching the posterior pharyngeal wall. If there is a nasal intubation, it will be difficult to do intraoperatively. If you have done preoperatively, that mark can go off. So using the right instrument here, I'm using a monopolar to divide in the midline. That is, I'm dividing the muscularis uvulae. And checking at each step. If you have overdone the midline cut, it may cause a velopharyngeal insufficiency. After a little bit of partial cut, we come up to the base of uvula and see by pulling both the segments laterally. I'll just fast forward it and we divide further as and when needed. So it is not you can't say 1 centimeter to be divided or 2 centimeter to be divided. Every step is depending upon the patient. It has to be tailor-made for each and every patient. So here you can see I have divided further up to the point which I have marked. Always assess. This will be better appreciated when you are looking under microscope. The three-dimensional depth of how much you have pulled. So preserving this mucosa is also very important. So I'll be talking about it. So that prevents velopharyngeal incompetence. Assess the posterior airway space during every step before dividing. And the pain management is also very important to prevent, basically, because of all the stitches, even with barbed suture or in Z-Palatoplasty, when you are started swallowing, the constriction which is happening will cause pain, and he will not be able to completely close his velopharynx, and there will be regurgitation. That is a temporary regurgitation, so nothing to worry about it. So dietary inspection. So liquid diet up to 48 hours, usually clear water or chilled drinks like Sprite or 7-Up or vanilla ice cream. Usually I prefer to have a colorless diet fluid so that it won't confuse you with whether there is any bleeding which is happening and the patient whether is swallowing the blood clot. Clear soup. Semi-solid diet usually up to 96 hours. Porridge or smashed rice, idli with milk or bread, something like that we can give. Usually after 5 days, start with the bland diet and routine diet, usually after 7 days, where the chance of infection is there. So pre-op, usually I give IV antibiotic 30 minutes before the procedure, and intra-op, repeat IV antibiotic if it is more than 6 hours. Usually that happens with multi-level surgery, and especially when you are doing maxillomandibular advancement. And I always prefer to give injection dexamethasone 8 milligram intravenously, and also in the post-operatively for the first 24 to 48 hours, followed by oral antibiotics and oral anti-inflammatory, betadine with hydrogen cargyl and proton pump inhibitors like rabiprazole or omeprazole. The next common thing which Sagar was showing that dreadful video is nasopharyngeal stenosis which can happen. So that how you are going to avoid that, that is by preserving this mucosa on this side. Usually the nasal side of the palatal mucosa has to be preserved much. If you are going to injure this area, that's going to cause stenosis, especially when you are going to combine this procedure with any adenoidectomy or something. So violating the border is most important. When you are going to this, preserving the mucosa lining is very important for preventing nasopharyngeal stenosis. So this pre-op counseling about the chance of nasopharyngeal is not that much important because it is very rare unless you are very violent, aggressive in the procedure, or when you are using very hot instrument. And handling of soft tissue, as I told you, is very important, and preserving the mucosa on the nasal surface of the velum. And when you are combining with tongue-based surgery, preserving the mucosa and the tonsillolingual sulcus is very important, because I have seen patients with narrow, partially, not complete, partial oropharyngeal stenosis following the procedure. So post-op, same protocol to prevent infection is in place here. So take-home message: training and knowledge about the OSA patient. Counseling is most important. Each and every step is to be explained so that they mentally will be prepared. Proper equipment and necessary team is to be involved. Complete evaluation and have a sleep board. As I told you, the patient is not going to be having just an upper airway obstruction, going to have many issues. So that all has to be addressed. And management of pain and prevention of complication and managing the complication is very important to have a very good successful outcome. So treat the patient, not the upper airway alone. So the right surgery for the right patient along with counseling is the key to success. So with William Osler's last statement, every surgery will teach you the tips and tricks. Thank you.
Dr. Vijay?
Yep. Hope I finished.
I was actually thinking how you would do this topic. Let me go on record and say it is beautiful. Thank you very much for coming in a holistic way and talking about each and every aspect, right from training to the use of instrumentation, pre-op, intra-op, post-op, and highlighting the role of counseling to the patients and mucosa preservation. So now that this part is over, I think we should now go for the most other important part, which is questions, which is equally important. There are a lot of questions, and what I could do is I could bunch them all together so that I could, based on the basic topic and the questions that they're asking, I can put it to all four of you. Shall we start?
Yes.
Yeah. Okay.
Yes.
Professor Lugo, I think you have a lot of questions to answer. Can you hear me? 1 second. Let me just.
Yes.
Can you hear me?
Yeah, we can hear
you.
Very well.
Okay, wonderful. So the first question is from Dr. Hernandez from Colombia. His question is, Dr. Lugo, are you making relaxation incisions in the posterior pharyngeal wall?
Yes, I using that kind of incisions in the lateral pharyngoplasty technique only.
Yes.
And in some patients we can see the passament ridge. The passament ridge is not very common to see, but in some patients they have, and this is important to make a little incision there to release the tension in that area. That ridge you can see in any technique, but the incision, the relaxation incision is very important in pharyngoplasty. Yes, in lateral pharyngoplasty.
Thank you. Another question to you from Dr. Eva from Poland. So she actually has two questions. The first question is, how often do you observe delayed bleeding in your cases of pharyngoplasty? Would you like to answer the first part of the question?
Yes, as Dr. Vijay talks in his lecture, you need to handle with care. The dissection of the muscle is very difficult, and it's very, you need to make step by step. And and you know the anatomy, and you see the variation of the blood supply there, and you need to make the dissection very slow and very very careful. Yes, it's one of the problems is the bleeding. We have some patients with bleeding problems, but thank God it's it's going bad, but you need to resolve in the operation room the problem. The tonsillar artery and the ascendant pharyngeal artery is one of the worries or that of the factors we very worried during the operation. And this is the reason we don't need to make holes there and to make a gross dissection, and you need to move the muscles. Is that the way to prevent the hemorrhage situations during the operation?
The second part is also similar. Say, do you observe mucosal necrosis or necrosis to your muscle flap when you elevate and rotate your flaps? And how do you prevent that?
Yes, the necrosis of the flap is very common. Is you dissect a lot in the lower part. Is one of the problems. You make a big hole there, a big virtual spaces there, and this is the problem. You can have a necrosis after the operation in the flap. I don't have any necrosis there, but the dangerous situation is in the lateral pharyngeal wide dissection. Is that the reason they changed the technique during the variations? The first technique, a lot of Pharmacoplasty, is so in my point of view is that was very hard to do. The dissection is so wide. Right now, in the last version, in the last modified Pharmacoplasty, is very nice. It's not that wide, and it's versus the first version is so replicate, and it's more easy to make. It's only in the upper part of the muscle. With that variation, we got the risk of that problem in necrosis.
The next question is also very similar by Dr. Chowdhury from Vijayawada. Same thing as Eva from Poland asked, how do you prevent muscle ischemia? So the next question is from a friend Carlos from Lima. He says, are you performing the new modification of BRP and how are you anchoring your suture? Are you anchoring to the hamulus? And how do you address and stabilize the anterior central part of the palate?
The modified BRP is prevent the floor of the palate, and is that the reason we make like the Alianza from Dr. Mantovani and Rinaldi is make a very a lot of loops in the upper part of the palate. Yes, we anchor the first loop in the hamulus, in the upper part, and the second loop is in the Raphe. No, is not repeat the operation, because if you repeat the needle insertion there, you have risk to make a lingual nerve injury there. Is that the problem in that area? It's so very, very close, the relationship between the nerve and the muscle, and the Raphe and the hamulus. The anchor in the middle part is not possible in the nasal spine. This is the first step of the technique always. But you make like a hammock, it's make a passing through the palate. The palate is over here, and you make the sutures over there, over the palate. And it is going well, but is there the modification? The second part of the modification or BRP is the dissection of the muscle. The first technique is only cutting the fibers and pull the muscle. But in our hands, the first BRP.
हमारा बंदा नहीं है, लेकिन मैं कराता हूँ कि थोड़ी देर रुक जाओ, मैं ये अपनी खत्म कर लूँ ना,
That's the reason we prefer the modified.
Just
Yeah. So, and you have Professor Big Kotecha from London, who congratulates you on a wonderful presentation, and he says, please comment on your long-term outcomes for your patient. How long do you follow your patients up?
Yes. Well, the first sleep post-surgical sleep study is in 6 months. 6 months after surgery. At the public hospital, we can follow the patients. We have a huge list there, and talk with the patients. The problems are similar in the literature. The patient is going fat. You know, any kind of surgery has that guarantee. The patient is going fat. The patient had a bad outcome, but the patients in 3 years outcomes is going very nice and going well with the lateral relocation patients in the upper part obstruction pattern, in the lateral obstruction pattern. We stopped to do sphincteroplasty. The reason is that we follow the patients in 3 or 4 years post-surgical, and the patient is going bad. The obstruction change, going to dice in one more time and repeat the dice and see the pattern in another type. In the previous surgery is anterior, or not, right now is lateral. The sphincteroplasty is upper lateral. Right now is complete. Is that the reason we stopped to do some surgeries to change to brand news. Right now, the 4 years outcomes to the BRP is going well, and the lateral pharyngoplasty in the selected patients, the outcome is very nice. In 4 years.
Wow, that's wonderful. Dr. Sandeep, next to you. Dr. Eva from Poland, she would like to ask you as to how far laterally do you usually relocate your palatopharyngeus in order not to lose the fibers of the palatopharyngeus muscle? Should you always reach the pterygomandibular raphe, or would you get away by not reaching the pterygomandibular raphe?
Taking like 3 to 4 stitches, so at least the first 2 stitches should reach up to the pterygomandibular raphe. Otherwise, we don't get good results.
Right. Okay. So Dr. Kotecha also congratulates you from London. He says, in your series, your average BMI seems to be about 26. What are your results in patients with your technique with high BMI? And do you have a cutoff BMI wherein where you feel your surgery will be inadequate?
Yes, definitely. This whole game of surgical intervention, I feel, is about BMI. So as Dr. Dolph was also saying, like if the patient grows fat, whatever technique you might use, the results are going to go bad. So my patients before surgery are also on they're seen by a nutritionist and or on a fixed customized diet according to the likings and dislikings of the patient, and after the surgery also. So we make sure that the BMI stays the same. I feel this modified relocation might not work very well. Like, of course, this is an hypothesis. I've not been able to, I can't validate it. Is after like more than 28 BMI, maybe it will not work.
So that's your cutoff point, basically. Pretty much. Okay. Dr. Vidyasagar, Dr. Hernandez from Colombia is asking you, what is your opinion about the dysphagia and the posterior droop? Okay, do you have what? Okay, let me just. So he says, what is your opinion about the dysphagia in your patients and without the uvula? I think he's talking about because it's a uvula sparing. You will have to.
Yeah, I
Yeah,
think it's
go
the
ahead.
foreign body sensation that these patients, for any palatal surgery patients, when we are chopping off the uvula, there is a chance that the patients will have a postoperative foreign body sensation. It is more annoying than any other symptom that a patient can have in the postoperative phase. So this has been explained previously that the posterior mucosa, the mucosa on the posterior part of the mucosa has the ciliary function that will have the sweeping motion of the mucosa that falls over from the nasal cavity to nasopharynx down to the oropharynx. So when you are altering the anatomy of the velopharynx, either by chopping off partially or completely or by relocating it, there is a chance that you are disturbing this mechanism. And that is why these patients may have this foreign body sensations. Yes, Zeta is also not immune to this problem. The patients post-Zeta will also have it. But only thing is, I have followed many of my patients in the post-operative phase. In the long-term follow-up, when the patient comes back for follow-up, I have asked the question of how you have this problem. Do you still have this foreign body sensation or not? You would be surprised to notice that many of the patients say that they are not having this problem, or whether there are two possibilities. One, maybe they have gotten used to this problem, or number two, because in the Zeta, we are not actually cutting off the uvula completely. We are only rotating or reorienting the mucosa. You still have preserved the mechanoreceptors and chemical receptors there. So still they may regrow or regenerate or redo its function in after few weeks or months. So that's what I observe.
Right, Sagar. So we have some more questions. I want you guys to be very crisp now. Okay, now it's rapid fire. Okay, I understand. Let's take it one by one. Okay, so one question basically is from Dr. Yogesh. Can your soft palate necrose if you don't suture properly? Any one of you can take those questions.
Tell me again, what is the question?
The question is, can your soft palate necrose if you don't suture properly?
It is not just about the suturing, Srinivas. It is about how you are preserving the blood supply to the soft palate, what you are reorienting and re-suturing it. Having said that, if you are going to make tight, tensioned sutures, then there is a chance you can block the blood supply to them, and thereby you can also cause ischemic necrosis. So these are the two ways you can have it.
Sure. So Dr. Vidyasagar D asks you, the release of posterior pillar will also help to retain the suture and not give up the posterior, give up in the posterior postoperative period.
Yes.
In fact, in all the palatal surgeries, if you release the posterior pillar, it will be crucial. Your opinion about that? I think let Sandeep answer that.
Okay.
Yes, definitely. I think so. Maybe a relaxation incision or a release incision is necessary to help to reposition your palatopharyngeus to a newer place, and it helps to not to like the just give away postoperatively in postoperative.
Sure. So
that's the basic idea of giving a relaxation incision.
Dr. Vijay, are you there? I think he's not there. There's a specific question by our Simab Sheikh to Vijay, but he's not there. Okay, Dr. Hernandez also asks, how early do you start myofunctional therapy? Any one of you can take that. How often do you start myofunctional? I think Professor Rodolfo, why didn't you take that? How often do you start myofunctional therapy?
I use the myofunctional therapy in all my patients. In the post-surgical patients, I always start the therapy 1.5 months after the surgery.
Okay.
We have exercise there. We can use the app from Dr. Carlos O'Connor from Spain. The airway gym is a nice tool.
Yes, I think so. Yeah.
You know, it's a muscle surgery. We need therapy to rehabilitate the occlusion, the movement, the new vectors from the muscle, and this is the reason my opinion is very important to rehabilitate the muscle movements of the oropharynx.
Fantastic. So another question by Dr. Yogesh Sagar. I think you should take this. What is the best suture for Zeta palato? The best suture. Is there a best suture?
It is always a tough question to answer, but the best suture that I use in my practice is 20 vicryl for the muscular and 30 vicryl for the mucosal. So, having said that, recently I've also started using Bob also for Zeta, but that has been only handful. But
I think I will take everybody's opinion. Sandeep, what is the best suture for you? The best.
The best is what you are comfortable with.
I think it's fantastic. I think that's a very good way of putting it across. Rodolfo, what is the best suture for you?
In the barbed ones,
I think in the barbed.
The Stratafix one.
Okay.
I use the B-lock and use the another type of sutures, and you know I prefer the Stratafix. The big needle is
yes.
And in the relocation technique, I use the 30 vicryl like Dr. Vijaya Sahar. This is a nice tool, and and we can use the 2 zeros in some patients with a strong muscle there, and the vicryl too. It's a nice suit.
Dr. Prakash Munkha, one of our best delegates, he says, in place of barbed suture, can you use any other alternative suture?
Yes. It's very difficult to replicate the BRP. Yes, you can mix the techniques, but you have some problems with the
Dr. Kotecha also congratulates you, Sagar, on your fantastic Z-Palatoplasty. I mean, it's huge that somebody like him is there.
Thank you, sir. Thank you.
He says it's a very brilliant, common sense approach. And do you give your patients patient information leaflet so that they can take it home?
Yes.
Dr. Kotecha is asking you that.
Thank you, Dr. Kotecha, for joining our OSA classroom session. We are really privileged to have you in our session series. Yes, sir.
Guys, one more minute. Please make it fast.
I do give the patient information booklets for them.
Okay,
yes,
great.
Both pre-op as well as post-op. Yeah.
Okay. Rodolfo, I think it's 1 a.m. in the middle of the night for you. I mean, really from the bottom of our heart, and I can speak for everybody in IASSA, we are very grateful for your kind contribution. I would request Dr. Sahai to, if he's around, to please come in and give us a word of thanks. Dr. Sahai, are you there?
Yes, I'm
Mr.
there.
Sahai, are you there? Yeah.
Yes, I'm.
Please come in.
I'm there. So
we
my
can't
video
see you.
Is not visible. I don't know why my video is not there.
That's all right.
Nevertheless, I'm there. So in fact, before we conclude today's 7th series of our webinar, let me take this opportunity to convey my heartiest thanks to all our eminent speakers who made that topic so interesting. In fact, the techniques discussed are practically implementable in a variety of patients. And I suppose if I don't over-exaggerate, patients suffering from sleep apnea are there in every single lane of our country. So thanks a lot, Dr. Naveen Patel, for conceptualizing the entire concept of IASA classroom. Extremely thankful to Professor Rulfo for his wonderful deliberation. Thank you very much, Dr. Sandeep Bansal sir, Dr. Vidyasagar sir, Dr. Vijaya Krishnan sir, and especially thanks Dr. Srinivas Kishore for beautifully portraying the event. Thanks a lot, audio and visual team. With this, we conclude today's webinar. Thank you very much.
Thank you, guys.
Before we conclude, the Friday is going to be all the international speakers.
Yeah.
So please join us back on Friday morning at 10 o'clock.
Friday, we have Dr. Peter Battista, Clemens Heiser, and Professor Capasso. So it's going to be a power-packed session from 10 o'clock. All of you, please log in.
Yes.
And Rodolfo, thank you very much again. Have a good night's sleep.
Thank you. I learned a lot with your presentation, Dr. Sandeep. A nice lecture. Congratulations for your techniques. Sagar, Dr. Patel, Vikas, Kishore, all my friends from India. Yes, I learn a lot always with you guys. You are so very good surgeons, and you know, you're a sample for everybody in the sleep apnea surgery world to follow your leadership in this area. Thank you.
Humble. Thank you very much.
Bye, Rodolfo. Thanks for waiting till past midnight. We all enjoyed your talk.
So nice of you to do that.